So I want to thank you and thank the organizers for giving me the opportunity to speak about this topic, which is particularly relevant, especially in this disease where we see so many young patients, and it's treated by both pediatricians and adults. So I'll start off by summarizing the spectrum of cancers that are seen in adolescents and young adults is quite different than the spectrum that you see in either pediatric or in older adults. So this is SEER data looking at patients age 15 to 29, and you can see that the most common malignancy is actually lymphoma, and it represents about 20% of the cases. And as we know, the bulk of these lymphoma cases are cases of Hodgkin lymphoma. And I think what's most interesting is that patients in this age range can walk in and be treated by a pediatric oncologist or an adult oncologist, and the treatments would be quite different. And there's actually data to support both of these options. Most pediatric clinical trials in Hodgkin lymphoma go up to age 30, and of course most adult trials will go down to age 18. So I've outlined the talk today in the form of two case presentations. So I'll present these two cases and then discuss management of them, including both the pediatric and adult perspective, discussing risk assessment, initial chemotherapy options, the use of response-adapted treatment, and the role of radiation, and with all of this kind of keeping in mind the important balance between disease control and late effects. So the first case here is an 18-year-old female who presents with neck swelling, fatigue, and night sweats. Physical exam is notable for bilateral lymphadenopathy in the neck. A biopsy reveals classical Hodgkin lymphoma. Laboratory studies are shown here, including leukocytosis, normal hemoglobin and platelets, and an ESR of 65. Imaging is shown here, which reveals bilateral cervical lymphadenopathy, an anterior mediastinal mass, and no evidence of disease below the diaphragm. So in summary, this is an 18-year-old woman who has stage 2B Hodgkin lymphoma without bulk disease. So I'll kind of go through this case first talking about risk assessment, then choice of chemotherapy, and the role of response-adapted treatment, discussing both the pediatric and adult approaches. So pediatric risk stratification actually differs among the various cooperative groups in pediatrics that study Hodgkin lymphoma, and even within a cooperative group, the risk stratification can differ for different clinical trials. And this is because the risk is very much based on the treatment approach that's used, and that's different among the cooperative groups and changes with time. And so in pediatrics, we divide patients into low, intermediate, and high risk. And the three major groups that study Hodgkin lymphoma are the Euronet group, representing the European group, COG, which mostly represents North America, and then there's a pediatric Hodgkin lymphoma consortium that consists of Dana-Farber, Stanford, and St. Jude. And so you can see for our patient who has 2B disease, whether or not this qualifies as intermediate or high-risk disease varies based on the different cooperative groups. And I'll focus mostly for the purpose of this talk on the children's oncology group approach, although the other approaches are of course valid as well. So adult risk stratification, of course, is different. Generally groups patients into early and advanced stage disease, and then among patients with early disease, patients are categorized into favorable or unfavorable, and the exact definition of favorable versus unfavorable does differ slightly between the German Hodgkin study group and the EORTC. In many US trials, however, favorable and unfavorable patients are treated on the same clinical trial, and the distinguishing factor to identify someone who's at higher risk for relapse is the presence of bulk disease, which is defined here. So for risk assessment for our patient, the pediatric approach, specifically through COG, would consider this patient to be intermediate risk, and the adult classification would define this patient as early unfavorable without bulk disease. So as far as the choice of initial chemotherapy, in pediatrics, the chemotherapy backbones that are used vary among the different cooperative groups. So the COG group uses a regimen that was derived from BIACOP but adjusted to reduce some of the agents that are most associated with significant long-term toxicities and specifically impacts on fertility. So this is a dose-intensive regimen that does not have procarbazine in it, but many of the other agents that are present in BIACOP at different doses. The Euronet group uses a different chemotherapy backbone, OEPA, which is vincristine, etoposide, prednisone, and doxorubicin. And the Pediatric Hodgkin Lymphoma Consortium has used a variety of chemotherapy backbones without one standard. However, they do have an ongoing trial that's currently open where they're using the Euronet backbone but replacing vincristine with brentuximab vedotin. As far as the adult groups and the initial choice of chemotherapy, I've listed here some of the relevant clinical trials that have been conducted among adults with early-stage Hodgkin lymphoma, and I won't touch too much on these. It includes the age 10, the UK RAPID trial, which we've heard about earlier in this session, and also the Alliance Cooperative Group. And I think just what's important to note here, as you all know, is that all of these groups use the ABVD backbone, and that's pretty universal among adult cooperative groups for early stage disease. So the initial choice of therapy would be different among pediatric and adult oncologists for this patient. At least within COG, we would use the ABVE PC backbone, and adult oncologists would use ABVD. So I'll talk a little bit about various approaches to response-adapted therapy and the role of radiation in early-stage disease. So for the pediatric approach, I'm going to focus on a recent children's oncology group trial that was conducted in patients with intermediate risk disease. This was a randomized phase 3 trial that enrolled over 1,700 patients, which is a very large study for pediatrics, and used a response-adapted approach. So all patients received 2 cycles of the ABVE PC backbone and then underwent a response assessment. And it's important to note that at the time of this study, PET was not universal, and so this was a combined metabolic and anatomic response assessment on this study. Patients were then classified as either a rapid early response based on a good anatomic response or slow early responders. Those who had a rapid response then went on to receive an additional 2 cycles of ABVE PC, followed by another response assessment after the 4th cycle of chemotherapy. Those who were in a CR were then randomly assigned either to involved field radiation or no further therapy. Those who were not in a CR were non-randomly assigned to involved field radiation. And it's important to note that in pediatrics, the treatment of involved field radiation for Hodgkin lymphoma is a lower dose than what's used in most adult protocols. It's 2,100 centigram. Slow early responders were then randomly assigned either to receive the standard arm, which was 2 cycles of ABVE PC plus involved field radiation, or an augmented therapy arm that included standard therapy plus 2 additional cycles of chemotherapy. So here's the outcomes for this study. Among those who were rapid early responders and in a complete response after 4 cycles and were randomized to receive or not receive involved field radiation, the outcomes with regard to overall survival, shown here in blue, and event-free survival in yellow, were identical in those who received and did not receive radiation, indicating that it's safe to eliminate involved field RT in this select group of good responding patients. And the outcomes overall, as you can see, were quite good, with a 4-year overall survival of 98.5% and event-free survival of 86.9%. For those patients who were slow early responders, if you look at the group overall, both in terms of overall survival and event-free survival, there really did not seem to be a benefit to the augmented arm that received an additional 2 cycles of chemotherapy. However, if you break this group down by those specifically who were slow early responders and had a positive PET. Remember, this was an anatomic and metabolic-based response, but if you limit this just to those that both were slow responders by both anatomic and PET, there did seem to be a slight advantage in regards to event-free survival for those who received the augmented arm, with an event-free survival of 70% in those who received the augmented therapy versus 54% in those who did not. So this approach is very commonly used among pediatric oncologists for patients with intermediate risk Hodgkin lymphoma. So the adult approach, I will not focus in the interest of time today on the RAPID trial, and it's kind of important to note that the RAPID trial did not include patients with 2B disease, which this patient was, so she would not have been eligible for this trial, or the age 10 trial, but these are very important trials which have been discussed earlier in this session, focusing on the utility of RT in patients with a PET negative response after 2 cycles. I will talk, however, about this clinical trial that was conducted through the Alliance Cooperative Group. This was patients with early-stage non-bulky disease who received 2 cycles of ABVD. Those with a negative PET scan after cycle 2 went on to receive 2 cycles of ABVD without radiation. And those who had a positive PET had augmented therapy with 2 cycles of escalated BIACOP and then involved field RT. And here are the outcomes in this group. So you can see those who were PET negative, who went on to receive chemotherapy without RT, have a 3-year progression-free survival of 92%, and those in the PET positive group, a 3-year event-free survival of 66%. So both of these approaches use response-adapted therapy to eliminate radiation for a group of well-responding patients, and I think both of these are appropriate approaches for our patients in pediatrics following the AHOD 0031 intermediate risk trial, and in adults, the Alliance trial. So we'll move on to our second case. This is an 18-year-old male who presented with night sweats, weight loss, and diffuse pruritus. Physical exam notable for lymphadenopathy in the bilateral neck and axilla. Lymph node biopsy revealed classical Hodgkin lymphoma, and laboratory studies are shown here. Here is imaging, which revealed lymphadenopathy above and below the diaphragm, including a 10.5 centimeter mediastinal conglomerate and focal uptake in the spleen. A bone marrow biopsy was performed and was negative. So this patient has stage 3B disease with bulk. So we'll go through the pediatric and adult approaches to evaluate and treat this patient. So for risk assessment, with pediatrics, there's a little bit more of a consensus for patients with 3B and with 4B disease in that all of the cooperative groups would consider this to be high-risk disease. So this patient would qualify for high-risk therapy on any of the cooperative group studies within pediatrics. Adults, as you're all familiar with, within patients with advanced stage disease often use the International Prognostic Score, and the elements that are components of that score are shown here. However, there's some evidence in the modern era, particularly for patients under age 65. This is data looking at outcomes for patients divided by IPS, and while there is some stratification here, you can see that these lines are starting to blur somewhat, and so the use of this varies among different groups as far as entry criteria onto clinical trials. So in pediatrics, a patient with 3B bulk disease would be considered high risk, and adults advanced stage disease, and this patient has an IPS score of 3. So regarding choice of initial therapy, this is a series of pediatric cooperative group studies that have looked at patients with advanced disease. And as you can see, the entry criteria for these studies does vary, so it's very hard to compare them against each other. However, there are some common themes. They've all used, or most of them have used, response-adapted therapy. And although the pediatric groups initially looked at regimens like BIACOP, because of the long-term toxicity associated with BIACOP, the Children's Oncology group has moved now to the ABVE-PC backbone for advanced stage patients as well. However, when using this in patients with advanced or high-risk disease, the doses of the chemotherapy used are slightly different, and particularly the dose of cyclophosphamide is increased for these patients. For adults, I've listed here a few clinical trials that have been conducted in adults with Hodgkin lymphoma with advanced stage disease, and I won't talk too much about the EORTC or Italian intergroup studies other than to say that these studies evaluated ABVD in comparison to BIACOP and didn't show substantial improvement in outcome with BIACOP treatment, and BIACOP is associated with increased toxicity. And so at least among US groups, the chemotherapy backbone of choice for patients with high-risk disease is also ABVD. And that's what's been used in a recent US cooperative group SWOG trial. This is a phase 2 trial, which I'll talk about further. So as far as the chemotherapy backbone, again, for high-risk advanced stage disease within COG, we would use the ABVE-PC backbone, and adults, at least in the US, would use the ABVD backbone commonly. So I'll go over the approaches to treatment, particularly response-adjusted therapy and radiation in both pediatric and adults. So this is a recent Children's Oncology Group trial. This was a phase 3 trial conducted in patients with high-risk disease. This was limited to patients with 3B or 4 disease, so quite high-risk patients. Patients received 2 cycles of ABVE-PC and then underwent a response assessment, and now this was a PET-based response assessment. So those who were PET negative after cycle 2 went on to receive 2 additional cycles, and then response-adapted RT, and what that means is radiation limited just to areas of bulk disease. And again, this is the 2100 dose for RT. Patients who had a positive PET scan after 2 cycles received augmented therapy with ifos and vinoralbine in addition to 2 cycles of ABVE-PC, and then modified involved field RT. So this was RT limited to areas of bulk disease and to slow responding lesions. So the data is not completely mature from this study yet, but has been presented in abstract form at ASH last year. And among the rapid early responders, the 4-year event-free survival was 83.5%. And among the slow early responders, those with a positive PET after 2 cycles, the 4-year event-free survival was 75.9%. And this data is similar to previous data in pediatric groups using this chemotherapy backbone. However, the difference here is that the use of radiation is reduced in this protocol compared to prior protocols. And I'll talk about one adult approach, although certainly there are many trials looking in this group, but this was the COG 0816 protocol for patients with advanced stage disease. Patients received 2 cycles of ABVD and then underwent a PET scan. Those who were PET negative received an additional 4 cycles, so 6 cycles total of treatment, and follow-up without radiation therapy. Patients who had a positive PET scan received 6 cycles of escalated BIACOP and then were followed without RT. Outcomes are shown here. This is 2-year event-free survival in the PET negative group, 82%, and in the PET positive group, 64%. So I think that this study is also important to mention when we're discussing advanced stage disease, and particularly the adult approach using the ABVD backbone. This is the RATHL study, or the Response Adapted Therapy in Hodgkin Lymphoma, very recently published in the New England Journal. So in this study, patients received 2 cycles of ABVD and underwent a PET scan, and those who were PET negative after the first 2 cycles were then randomized either to receive standard therapy with 4 cycles of ABVD or therapy where the bleomycin was omitted and AVD treatment only. And I'll focus just on these PET negative patients for the purpose of this discussion. So this is progression-free survival among the patients who were randomized, and you can see the curves are almost completely overlapping between those who went on to receive standard ABVD and those for whom the bleomycin was omitted. And so this indicates that perhaps for these patients with a negative PET scan after 2 cycles, that it's safe to omit bleomycin, which, as we all know, is associated with significant both short or long-term toxicity in these patients. So I think as far as treatment approaches for patients with advanced disease in pediatrics, the 0831 COG protocol is commonly used, and there's actually an active ongoing trial, which I'll discuss a little later on. And among the adult groups, both of these, the SWOG or the RATHL study, are appropriate approaches. So I've been discussing the various regimens that we use in pediatric and adults, but haven't really discussed which we should use in an adolescent and young adult patient, and that's because we really don't have the data to be able to make these decisions. And so I think the real question is, have these studies been compared head-to-head? And as you can imagine, it's quite complicated to do this because they each have different entry criteria, so not really comparing apples to apples, but Tara Henderson and Andy Evans have started to do this, conducting a comparative analysis looking at the adult intergroup trial 2496 and comparing that with the Children's Oncology Group AHOD 0031. This is the intermediate risk study which I spoke about. This has been presented in abstract form, and again, the analysis is complicated because there are different entry criteria for the two studies, but looking among patients aged 17 to 21, this is the outcome for the adult patients with an EFS of 68%, an overall survival of 89%, and the pediatric patients with an EFS of 80% and an overall survival of 97%. What was interesting is that for reasons that are not entirely clear, this age group on the E2496 trial did not do as well with regard to event-free survival as some of the other older age groups on that trial, and the reason for that is not entirely clear. But nonetheless, when you compare this data, comparing those treated on the pediatric regimen with those treated on the adult regimen, there was an improvement in event-free survival for those patients who were treated with the more dose-intensive regimen on AHOD 0031. And that is taking into account a multivariate analysis that included things like stage and bulk disease and anemia, which did differ between the two groups. So I think there's a lot more work that needs to be done, and I think this opens up a lot of important questions about how to best treat patients who are in this age range. So what's ongoing right now? In pediatrics, they're in the low-risk group. The only open clinical trial is being conducted through the Euronet group. There's not a US clinical trial in low-risk disease. In high-risk disease, there is an ongoing phase 3 randomized trial, and that's looking at using the ABVE PC backbone and randomizing patients to either receive this or treatment where the bleomycin is replaced with brentuximab vedotin. Among the adult groups, there is an ongoing alliance cooperative group study looking at patients with early stage bulky disease, and that's also a response-adapted approach. And then this phase 3 study in advanced stage disease has recently closed to accrual, and this study compared ABVD with brentuximab vedotin plus AVD, and I think we're all kind of anxiously awaiting the results of that trial. So in conclusion, while the chemotherapy backbones and the use of radiation and the dose vary between pediatric and adult groups, I think there are some common themes here, specifically risk and response adapted therapy, reducing therapy in patients with an early response to reduce long-term toxicity, and more recently, adding novel agents to upfront therapy. And as far as future directions in this area, I think it's very important to study this age group, and there is an AYA-specific protocol that's currently under development. This is a joint protocol between the Children's Oncology Group and the Adult Alliance Cooperative Group to specifically study treatment and outcomes in this age group. So I'll stop there, and thank you for your time.